Hello, everybody, and welcome to the first Conversations and Aesthetics podcast. I'm your host, Gary Goldenberg, dermatologist in New York City. And for this first episode, I'm so excited to have our first guest, Dr. Mathew Avram. Matt, welcome to the show.
Gary, thanks for having me. It's a pleasure to do this. Thanks for the invitation.
Well, we're going to talk all aesthetics for the next 45 minutes to an hour or so. And who better than you to start us off with this exciting new podcast? Why don't you tell our listeners a little bit about yourself, your practice, what your interests are, et cetera?
Sure. So I've been the director of the Laser and Cosmetic Center at Massachusetts General Hospital for 20 years now. I actually was an attorney in New York for 3 years and made a career shift. And so this is an academic practice. So we have residents and fellows here. There are about 30 to 32 residents in our program. There are 2 cosmetic fellows and a Mohs fellow that go through our clinics. And I'm also associated with the Wellman Center for Photomedicine, which has developed a lot of these technologies. And through that, I've gotten involved in technologies that they've been developed with lasers and light sources, as well as injectables. It's an aesthetic practice, so we do a lot of injectables, peels, and other treatments as well. And I've been active within the dermatologic community as the president or former president of the American Society for Dermatologic Surgery and the former president of the American Society for Laser Medicine and Surgery. And I see patients 5 days a week.
And that's just your concise resume. That's the Cliff Notes. And you know, you're well known, obviously, in the dermatology community, especially in aesthetics. And when I think of you, I always think of laser advancements and technology. So I think all of us appreciate how much you've contributed to our field, not only from a medical perspective, but also especially aesthetics. So, Matt, you're seeing a patient. First time somebody sends you a consult, maybe another derm, maybe they find you on Google or ChatGPT. You go in and talk to them. What is your definition of a success when it comes to a cosmetic procedure?
You know, it's interesting. We have to remember what cosmetic procedures are at their core. They're elective. And it's important. This is different than any other interaction we have in medicine, because at the end of the day, if someone has a melanoma, they have pancreatic cancer, or an emergency situation, you have to treat that patient. We're in an entirely different realm when it comes to aesthetics, because it's not medically necessary to do these treatments. So I think the most important thing up front is for the patient, for you to understand your patient and to understand what they're coming for and whether or not you can deliver on what they seek to get. Patients have a very different set of expectations. Most of the time, they're relatively reasonable. Sometimes they're unreasonable, and they're things that you can't do. When someone is doing something that is elective and they're paying out of pocket for it, your degree of toleration for adverse side effects or disappointing someone is very different than if you're doing something that is urgently needed medically. I think at its core, that's the biggest thing to keep in mind when you're seeing aesthetic patients is, are you going to be able to help this patient? Do they have realistic expectations? And are they going to leave happier? And are you going to be glad that you treated that patient? So that's a unique part of aesthetics. And with every patient, when they check in, when they see the nurses, if they see a resident or a fellow before they see me, what we always talk about is what they're there for, whether or not their expectations are reasonable, and whether or not we can deliver them. So those are the keys to every visit, even more than the science.
I think you said something that really goes to the core of a cosmetic patient. And for me, it's about setting the right expectations. You know, we don't do facelifts. Some dermatologists do. I don't. I know you don't. So there are things that you have to set realistic expectations. And I think people sometimes come in with unrealistic expectations of what they can do with, one syringe of Restylane or Juvederm, or, a little bit of botulinum toxin. So you go in there, and I know you're very charming, and I'm sure your patients love seeing you. How do you set those expectations? What do you tell people? How do you set the guardrails? Because for me, it's very easy to sort of overpromise and underdeliver, and I feel like you never want to do that.
Yeah, Gary, that is, I think, the most important part of seeing cosmetic patients is framing the expectations appropriately, having a conversation where you can convey that to someone. And a lot of it has to do with how, your sense of what the patient's coming for and how realistic their expectations are. It's difficult because, you don't want to dissuade someone from getting a treatment, but I'd much rather turn away patients that might do well than treat someone who is never going to be happy, because that makes your life a little bit shorter, makes the patient unhappy, makes you unhappy. So I think the most important thing is just to frame things very directly and very realistically. I tell patients all the time, listen, I've been doing this a long period of time. There's a variation in the outcomes that happen. I can't predict exactly what's going to happen with you. I think we're going to help you. I think you're going to get better. But when you get into treatments that aren't as directly impactful, such as tissue tightening, which I spoke about with a lot of and performed a lot of patients this afternoon, that conversation is going to be different than if you're treating a cherry angioma or a Lenigo. And it's very important to repeat things and to make it very clear to patients, so that I found that if you set the expectations correctly and for some reason, things don't go as well as you'd hoped in terms of a home run result, the patient knows that you've told them that, because that's just the nature of what we do. You don't want someone to be surprised, because if they're surprised, they're going to lose faith in you when you remind them of something you'd said earlier. And a lot of that also goes to the fact of whether or not you think they're listening to you. Sometimes patients will start bargaining with you. They'll
For
start
sure.
saying, so you say I'll get about, 50% better if I do 4 treatments, but you could probably do it in 2 treatments and probably get to, and I say that to them, say, listen, bargaining may work, in a market somewhere, but it isn't going to change science. So you have to listen to the patient. If you get the sense that they are not going to be happy, or if they're looking for something that they're not going to be happy with, the most important thing to do is to explain that to them. And what I will often do is, hey, listen, I'm not sure I can accomplish what you're looking for today. Maybe you may want to see someone else and see if they have a better idea than I do. I'm not the be all and end all here. And I will often, this is a personal decision. I will refund the consultation, just say, use this and talk to someone else. Maybe they have a better way of achieving your goals. I'm just concerned that we may not be able to do it for you, because it's funny, over the years, I've been fortunate enough not to have too many patients get upset with me. The common denominator is that the patients who've been most upset with me have been people who I have decided not to treat. And they'll say, I don't feel that he listened to me. I don't think, but the reality is, had I treated those patients and they were upset with the results, it would have been a lot worse. So
They're going
I
to be upset regardless.
yeah, exactly.
Some
So
people are
you
going
might
to be
as well,
unhappy regardless. That's right.
take a hit up front and then just treat people safely and effectively. And typically patients are very happy. I think the consultation, which is what you asked me about, Gary, at the beginning, is the most important part of the visit. And I'll say something, you don't need to be a lawyer to know this, but there is no legal obligation to inject a botulinum toxin in someone's face or to perform a fractional laser. And if you feel like they're not going to be happy with it, then, so be it. You give your medical judgment. If they're not happy with it, then let them be disappointed. And by the way, overwhelmingly, people appreciate that you're being honest with them. But there are going to be some people who are never happy, like you said. And I think that's the most difficult part of navigating an aesthetic practice is understanding patients' expectations and having an honest conversation with them. And if they're not listening to you, my advice to you is not to treat them.
It's amazing. I'm listening to you talk, and I think about how much psychology there is in medicine in general, but especially if you're doing aesthetic selective procedures. And, I study psychology, and I continue to read books on, negotiating with people, or sort of how to approach different personalities. And I think it's so helpful. And one of the ways that I set expectations, I like to use numbers, because I think people get it. So if somebody comes in, they want a skin tightening procedure, or they pull up their face and they say, I want this, but I don't want surgery. I'll say, okay, well, if a facelift from, somebody who I use in the city here in New York City is like a 10 out of 10 or a 9 out of 10, I can maybe get to a 3 or a 4 out of 10. And I think people really understand that. And I think it's always very helpful to kind of set that right expectation.
I think that's a great way of putting it. What I tend to do is I say, listen, if this is where you are now and this is a facelift, we'll get you maybe somewhere in there. I said, if you do nothing, you're going this way. We're never going to get you there. And you need to know that up front. And I do a bell-shaped curve, and I'm like, there's a 10% chance in either end. You may do really well. 10% chance you're going to see nothing. 80% you'll see a small but noticeable difference. And if that isn't acceptable to you, don't do the procedure. We're not going to harm you. Nothing bad's going to happen. But you might feel that you spent money and didn't see the result that you wanted. And if that's something that is an unacceptable risk to you, I'm telling you, don't do this. And I like what you said about the comparing it to a facelift, and we're saying kind of the same thing. It's funny. I do think that a lot of this is psychology, and it's interesting. We did a study. Patricia Ritchie, one of my former fellows, reviewed 2,000 charts of people who came to medical dermatology and people who came to our laser center. Our laser center is 100% aesthetic or procedural. Port wine stains, you can argue, are aesthetic. And she looked at which patient population used more psychotropic medications, and it was the cosmetic patients. And this was a deep review. She really, because we have Epic, she went into the weeds and really reviewed the charts. It was incredible how much work she did. So there's actually data that goes along with that. And you could think, well, maybe those people are more likely to take a medication or more interventional, whatever. This is derm patients in the same hospital versus cosmetic patients, the same hospital, same community. And they were matched for age, gender, all of the other stuff. So there's some data to indicate that as well.
It's certainly very interesting. I mean, I notice just how many patients are taking, medications for mood. And I think the prevalence of, mental health problems in general in our population is certainly increasing. But I think especially for patients that have unrealistic expectations, or patients who just keep asking for more procedures, and you're like, no, your lips are big enough, your cheeks are big enough, you don't need any more. In fact, you probably have too much. I do think that there's a lot of psychology that's involved there. So let me just kind of move forward and ask you, you think about your day. What is the most common patient that you see? Who is that prototypical patient that comes to see you? And what are the most common procedures and concerns that you address in your practice?
That's a really good question, because that's changed over time. When I first came here, Boston cosmetically is very conservative. Politically, it may not be conservative, but cosmetically, it definitely is. And when I first came here, it was a 52 to 57-year-old female patient who started off by saying, I'm so embarrassed to be here. I feel so vain coming here today. So fast forward 20 years, the age has gotten considerably younger, and there are different modes of distribution. I would say now it's probably 40 to 44-year-old female. There's been a big bump in kind of 28 to 34, 27 to 34 prejuvenation. Then you get kind of 40s, early 50s. The most common things so the most common procedure we do here is botulinum toxin injections. And this is a center. We have dozens of lasers. It's known for lasers. Botulinum toxin as a single procedure is number one.
It's a gateway
Number
drug.
two, yeah.
Botox or whatever you're using is a gateway drug.
Yeah, and if you do lasers as a whole, it's more than toxin, but it is. And then the next most common procedure is vascular laser, and then after that is fractional laser. So those are the three most common things we do. I would say things that have become more common are something that's dropped off the face of the earth is cool sculpting. You asked me that question 8-9 years ago. I'd say we do a ton of that. We do very little now. And we do a lot of tissue tightening now as well. And that kind of came with, things like this, Zoom, FaceTime, people seeing themselves on camera for the first time. That really increased tissue tightening, and also this idea of prevention. So yeah, those would be the most common things that we do.
It's interesting you said about cool sculpting. I read a lot about GLP-1s and their effects. And, I see a ton of patients who've lost, 20 pounds and their face has dropped or their buttocks have dropped or their breasts have dropped and they need to replace some of that fat. Even though if you look at the data, most of the GLP-1 fat loss is visceral fat, overwhelming, 80 to 90% is visceral. So the fat pockets like the submentum, the abdomen, saddlebags, bad arms, whatever you call those things, they remain. So, to me, it seems like those procedures are actually going up because plastics are doing more and more liposuctions. And the numbers do show that's one of the most common complaints in those GLP-1 patients. So it's very interesting for me that you're not seeing as many cool sculpting patients in your center.
We're seeing some. It's interesting. We are seeing a lot of the patients who want tightening, and some of them are way too far gone. They just have so much laxity. They lost 100 pounds. And let me
Sure.
say, someone who did a lot of work on fat with like the cool sculpting stuff and then the Kybella stuff. These GLP drugs, as we all know, they're phenomenal. I mean, they work incredibly well. So they've created a tightening market for us. Um, and I think there's definitely a role for cool sculpting for the exact reasons that you said. This is something that it really started decreasing, I guess, a year or two after COVID for us. It just changed
Mhm.
completely. And we still get patients coming in, but not in the same way that we used to. But the tightening, because of the GLP, has definitely increased for the reasons that you said.
Yeah, it's interesting because I read a report where they looked at over 1,000 patients who were in GLP-1s, and the number one concern was loose skin, and number two concern was local fat deposits. So it'll be interesting. Maybe we'll have this conversation again in a year or two and see if those trends have changed, where you're seeing more of those patients. So something I want to focus on for a second, Matt, you mentioned
Hmm.
sort of the younger patient, and to me, that's all social media influence. I think that, for an aesthetic doctor, Zoom or whatever, meeting, whatever meeting platform you use and GLPs have really transformed our practice because more and more people are seeing aesthetic doctors. But for me, I think selfies and social media have really reshaped not only the number and the age of the patients that we're seeing, and also I think we're seeing, at least I'm seeing more male patients because they also
Hmm.
want to look great in photographs. It's not just the female patients. But what do you think of the social media revolution and how have you seen that affect what you do in the office?
Well, first thing is, it's really interesting about the whole Zoom thing. I first got a glimpse of this. This was probably when I was first couple years in practice. Television went to high definition television, and the people could see much better definition. And I started getting people who were news anchors coming in and saying like, "Hey, people are seeing, I need to get something done. I'm seeing lines that I never saw before." Then I've had some of the patients who've come with cataracts and they get their cataracts taken out. They're like, I look terrible. And it's funny, I saw this as kind of the same way. So for the first time in human history, people are seeing themselves like now I'm talking to, I can see a video of myself speaking to. That never happened before. So people got on Zoom, they got on FaceTime, they're on social media, and so they're seeing themselves in a way that they never saw themselves. And some of it's lighting, but most people don't see themselves this way. And so there's that aspect that got us much busier. And that was something I thought when COVID happened. I was like, who's going to come in for a laser again? And it ended up being the opposite. The flip side of that, and I think that's what you're asking about, is well, what about the content on social media? And that's a whole other can of fish. So we have more patients coming in, we have younger patients coming in, but there's more information than ever from people who know less about what they're talking about than ever. So
The
you have all these,
influencers.
yeah, the influencers who don't know anything about medicine, aesthetics, are confidently expounding all their ideas on what works with aesthetics, and that creates problems because if people are coming in with unrealistic expectations, you have people I think who are trying to get treated younger when they don't need it as much as they think they do. And 4 years ago, everyone had huge lips. That was the trend. And then at some point, people started deciding that they didn't want the big lips. And now the whole thing is people want fillers less and less. So it's good to be aware of the trends. If you listen to your patients, you're going to hear them, but you can see the stuff online. So what bothers me about what's online is number one, that people who really know next to nothing about this are being viewed by millions of people, and people unfortunately figure that if a lot of people are watching you, what you are saying must be true. The other thing is I think sometimes people game the system a little bit. And I've seen people who do more surgical procedures try to knock procedures that are non-invasive and raise questions about safety and things like that that are completely unfounded because it's in their interest to do that. And I think there are people who are misinforming about the safety and benefits of very safe and effective treatments, including filler, and they're doing a disservice to
Agreed,
patients and something
100%.
that, and unfortunately, it's people in the physicians in the aesthetic space. Again, I'll just say it gently, as people who may do things surgically more. And what's interesting about that is I mean, financially, they're going to benefit from doing larger procedures. They pay much more money. On the other hand, some of the people saying these things have these devices in their office. So that doesn't quite make sense to me. But so you get more confusion with patients. And what you have to do is just look them in the eye and tell them what, what the science is and why you do it and what the risks and benefits are and how it makes sense. And at the end of the day, you know, people don't say this enough. The great thing about dermatologic surgery, toxins, fillers, um, lasers, and I'm going to say particularly lasers and energy-based devices. Toxins and fillers are a little bit different, but lasers and energy-based devices, the one thing you're not going to make someone look is artificial. If you do a fractional laser on someone, they're not going to look like a different person. And that's actually one of the biggest cosmetic fears that patients have. So you can knock tissue tightening fractional lasers, but you're going to look like the same person when you're done. You're not going to look puffy. You're not going to look pulled with tissue tightening treatments too. And I think that's actually an undersold virtue of these devices because that's what most people want. They don't want to look when they're 55 like they were 25. They want to look like they came back from vacation, they look good, their skin
100%.
reflects well. So we don't do a good enough job of communicating that incredibly important benefit to patients. And it isn't something that translates well on social media in terms of before and afters, but that's what we do. And that's what patients actually want.
I agree with you 100%. I tell my patients all the time, if you're 45, my goal is not to make you look 10 years younger. I want to make you look the best you can for where you are in life. You know, you're going to look 45. You just want to be the best looking version of yourself that you can be. And you can do that with toxins, filler. I'm using Derma PRP filler, which has been working well. Energy-based devices. I think you put all of those together, and I think you can really optimize someone's appearance. Something you said very interesting. I personally I love the influencer culture because I think some of it's like pure comedy if you really pay attention to what people have to say. So pretend that you are an influencer, okay, Matt? Tell me about nutrition and what you talk to patients about because I find that every one of my patients, medical or aesthetic, they want to know what they should be eating, what they shouldn't be eating, how much water they should be drinking. Do your patients ask you those questions and what do you say as a dermatologist?
They do. A lot of times people are more focused than that, but it absolutely comes up. And I think, you know what? I think aesthetics and medicine are kind of coming together, and there is kind of like a continuum between aesthetic health and wellness, and they're all tied to each other. So it makes perfect sense. The healthier you are, the better your skin's going to look. And what we're finding with the lasers is that lasers actually improve the health of your skin. So you do a fractional laser, you're replacing older skin cells with newer skin cells that are more functional, that can handle the sun better and decrease your risk for cancer. That's true with vascular lasers too. And as it turns out, so these devices are actually making your skin healthier. So there's a health slash wellness side and there's an aesthetic side. With nutrition, I mean, high glycemic foods, not a great idea. Diet, exercise, hydration is great. If you just even for the moment, the more you drink, the less kind of dehydrated, the more, your lines aren't going to be as noticeable. So all of those things are actually really important part of that. And I think the good part of emphasizing that is you can tie in what we do with the health aspects of that. Again, the devices are making your skin, from everything we're learning, making your skin healthier. And then if you're eating better and you're healthier, you're going to do better. And people intuitively understand that. So I think we need to do a better job of tying those, and that is something that comes up. And I, exercising is a great idea. We have medications where you can lose weight really well, but it's great if you go to the gym, you walk, and again, walking 20 minutes a day helps a lot. So all those things come up, and that is really important and growing area.
Yeah, I love what you said about wellness and aesthetics kind of joining. And I work with a few longevity and rejuvenation doctors who are internists here in New York City. And, we always have the same conversation. It's not just about what you're doing to your skin or aesthetic procedures. It's hydration, it's nutrition, it's keeping your sugar levels low. It's maybe taking something like metformin for anti-aging. It's doing a lot of different things that will improve your general health because, I know we all say this, beauty's from outside in and inside out. And I think it's all true. And I think this is a good segue for us to talk about regenerative medicine because I know, I've been talking about it for 10 years, maybe longer. I know you're very passionate about it also. So why don't you talk to our listeners a little bit about what your view is on regeneration and how it affects skin health, et cetera?
Yeah, I mean, that's something that we're learning more and more about. And, I'll start with the fractional lasers. I remember sitting in this office speaking to Rox 20 years ago about different experiments we might be doing. And Rox was like, if we're only treating a fraction of the skin, his worry was, well, the skin, the cells that are the most atypical are the ones that are going to, re take over the skin, and that you'd actually create more atypia. And I was like, wow, that's a good point. That makes sense. And then you fast forward, and I did this for, at this point, about 15 years. I was looking at my patients, and I was like, these people seem to be getting less skin cancers, the ones who had a lot of them. Their skin looks better. And I just, for myself personally, the areas where I had the treatment versus like closer to my eyes, where I didn't, felt like my skin looked better. And we started looking at our data, and we saw that people were having fewer skin cancers. And then we looked at more data and showed that people's were handling the sun better. They were creating more collagen. And what it turned out was, it's actually, when you put this patterned injury in the skin, you get new cells that come in, and those cells are stronger, healthier, newer, and they replace the older cells. We have that with pulse dye lasers as well. We found the exact same thing. And there was an interesting paper, I forgot, it was in Nature Science, one of the main scientific journals, and I don't think many people looked at this article. It was very simple. It was mice, not humans, so who knows if it's true in humans. But they had RAS mutations, which is the mutation for squamous cell, and then they had regular skin, and they just did a single punch biopsy. And what it showed was that when you do the biopsy, so before the biopsy, the area where the mutations were replicating much more than the normal skin. When you do the biopsy and you create a wound, the exact opposite happened. The skin that was wounded started replicating more quickly than the carcinogenic cells. And I think that's what's going on here, is like, if you think about it from like, and this is a theory, but I think it makes sense. If you think about it from an evolutionary perspective, 30,000 years ago, you're running in a forest and you cut yourself. If you don't get good wound healing, you're dead. So I think your skin and your cells regenerate very quickly because, as a means of survival. I think when you do a laser and you put in a patterned injury in a very orderly fashion, that helps your scars look better. But what it's also doing is you're creating wound healing that is overcoming whatever neoplastic changes there are from sun over the years, and you're getting newer, healthier cells that are outstripping the cells that were causing problems. And so you are in fact making your skin healthier. So to me, that's, wellness, regenerative medicine. That definitely happens with fully ablative lasers and fractional ablative lasers. And the question is does it have to do with heat or is it just a pattern injury? Because in that study, it was just a punch biopsy. And again, it was mice. It was like a little, nothing, a little thing. But I'd be curious to see over the years whether or not it turns out that any kind of patterned injury gets you kind of newer, healthier skin. So I think that part is super interesting, and we'll see where it takes us. But to weld wellness and aesthetics and medicine is, it seems like that's what we're doing more and more. And the more evidence we have of that, the more patients are going to like it. And the better, the more good we're doing for people. If, again, going back to the 54-year-old female who came to me in 2006 and said, I'm so embarrassed here, I feel so vain. Well, you might feel like it's being vain, but what we're doing is making you healthier. And it's whatever, it's your skin. Who knows if it works in other parts of the body as well, but these aren't just aesthetic treatments. So it's an exciting time, and I think the more we learn about this. By the way, the other things you were talking about, nutrition, things like that, they play a big role. I want to say one other thing about health, which is really important. People used to smoke a lot more, terrible for the skin, and drinking. Hey, you want to get better and you want to make this a wellness thing, maybe cut down on the drinking. That's not good for your skin either. So there's so many different ways that what you do that makes you healthier is going to make your skin healthier and make you look aesthetically better. So the whole thing's kind of coming together now. And it's just cool stuff, for stuff, we think about these as beauty treatments. They're much more than that. And that's going to be a big growth area for what we do day in and day out, medical and cosmetic dermatology.
I could not agree more with you. I feel like a lot of the things we do are truly anti-aging, and that comes with regenerating normal skin cells opposed to damaged skin cells, which is usually UV damage or pollution damage and whatnot. So I feel like when you are doing procedures, you're not only making somebody look better, you actually are making their skin better, which I think is exciting. I know I talk to patients about this all day long. Sometimes I'm tired of hearing myself say the same thing over and over again because I say it so often. So I appreciate that you have this similar view and kind of this aesthetics and wellness coming together. So speaking of, yeah, go ahead, please.
One quick thing. I want to this is a shout out to my fellow dermatologists out there. We got to get this message out more. So we were talking about social media earlier. We need to be quicker to embrace this stuff because this is literally, these are dermatologic procedures invented by dermatologists, studies done by dermatologists. We need to take ownership of this. These are our bread and butter. And I've got to say, people are physicians and not physicians are doing a much better job of speaking to people about this than our colleagues are. So I just want to put out a plug for the dermatologists watching this, that this is something that you need to embrace and discuss with your patients. Many of you are, but I think we can do more of it.
Well, I think that one of the things that I wish I studied more earlier in my career is communications and how to communicate and with patients and other physicians and, how to really build rapport. And I feel like you're really good at this. I feel like a lot of our colleagues maybe haven't gotten that training. So I feel like that should be part of a curriculum of medical school or residencies, really developing a communication style, not only with your patients, but also with, media in general. I think that's very, very helpful. Now, I know you brought some things to show us. So I want to make sure that we have plenty of time to go through the videos of you doing procedures.
Sure.
So maybe we can start with that and then we can talk through some of that. Matt,
yeah,
so
sure.
Lou, let's bring up the first video if you can.
So this is a pulse dye laser. This is the V-beam with a patient who's from in New England area, has a lot of telangiectasias. You can see the yellow light flashing. So that's the 595 nanometer laser. So we know that this helps with telangiectasias, rosacea. What I wanted to point out, the reason I showed this video is that we published a study probably like June of 2025. So recently, that showed, we looked at patients with an average, so it's a retrospective study, patients who got the V-beam laser, cosmetic patients, or cosmetic patients who didn't get pulse dye, and some of them were 532, to be fair, versus those who maybe got a toxin or they got seborrheic keratoses or they got a filler. So these are cosmetic patients, match controls completely. And the ones who got the pulse dye laser had a 50% decrease incidence of skin cancers. Now, a couple of things. You're going to say, well, they've stayed out of the sun. Trust me, the cosmetic patients who come here are very good about sun avoidance. The other thing I point out is that 80% of the skin, so they all had a pre-existing history of skin cancer in both groups. It turns out that sunscreen, there's very good evidence to show that sunscreen decreases the risk for squamous cell. And again, I'm going to maintain these patients, both are very strong. Both groups use a ton of sunscreen. Basal cell, there isn't really evidence to show that basal cells are prevented by sunscreen. Those 80% of the skin cancers in the study. I don't think this is an accident. I don't think it's a coincidence. And the p-value is 0.00047. The laser is preventing skin cancers. We don't know exactly why. I think it might be what I was talking about earlier, that maybe you're just creating, these micro wounds in the skin's healing it, bringing new cells, new collagen. And Gary, I'm sure you've seen patients who've gotten, vascular laser treatments. They tell you their skin's smoother afterwards. I think that's the same story. It's possible that, these lasers can actually help treat some early skin cancers as well. We did studies showing that, but that's important data getting back to wellness and health. So that's why I just wanted to show that this is new stuff. It's no laser, but again, we looked at average follow-up time is 8.5 years. Huge significance between the patients. You have to treat a lot of patients to get the data on this, and it's only like 125 patients total, but the data is pretty compelling. It's something that we noticed and the study confirmed.
So 2 questions for you, Matt, in follow-up to this. One, about the skin cancer stuff. Do you think it's because of vasoconstriction? You're restricting blood flow to potential tumors or cells that need more blood flow to replicate? So that's a skin cancer question I want you to think about. And the second one is about rosacea, because I know that there's all this debate. Is it a vascular issue or is it an acneiform issue? Where do you stand on this?
Well, those are two really good questions. I'll start with the rosacea part. Turns out the rosacea is an independent risk factor for skin cancer. And that'll get right back to what you're asking. Vascular, inflammatory. So I think that if you cut the vascular supply, I think you're going to get fewer skin cancers. And it could be that maybe there's some early ones that you're zapping early. So I think, and then in terms of the treatment, so the rosacea part, if you cut back the rosacea, it would make sense if you cut back the risk of skin cancer, and then, getting to the vasculature, reducing it, or maybe stopping what might be like an early, at least with the basal cells. So we've studied those closely. Those are very arborized entities, as you know, and the vessels in basal cells tend to be larger than the surrounding vasculature. So I think they're easier targets. So I think it's all of that stuff. And I think it might just be the injury to the skin as well. So I think there's specific things that you mentioned to vascular lasers in terms of going after the blood vessels, and maybe plus or minus just the injury to the skin. So really fascinating stuff. The short answer is I don't know, but I think you're on the right track, and I think that's probably what the story is with these.
Yeah, I'm with you. All my rosacea patients, whether they have redness or just they have papules and pustules, I think everyone benefits from vascular laser. I have a KTP laser that I use, but I think it's really laser agnostic. Anything that targets vasculature, I think, is going to help. So that's
I agree with that.
Very interesting. Okay, Lou, let's bring up the next video.
So this is a new device. This is the kind of the latest thing that's come out of the Wellman Center. And so this is Rox Anderson, Dieter Manstein, and Henry Chan's work. This is a new form of fractional laser. It's called Aveva. And it's the same wavelength as the Fractional 1550, but this actually does something different. So the regular Fractional, you have like a collimated beam that goes into the skin, and you have like these little channels, these cylinders that go into the skin. This laser, what it does is it deposits very little energy superficially at the epidermis and deposits much more in the dermis. So what it does is, with a regular fractional laser, you have kind of energy going all the way down, and there's plenty delivered superficially. This one is kind of putting most of the energy deep at much higher energies. And actually on the skin, if you looked at the skin, it actually, I'm exaggerating the size by like 1,000 times, but it's a ring. So the middle of it, there's no laser at all, but on top of the skin, there's this little rim where the energy is going. And then if I put the skin this way, the energy is going down into the reticular dermis, and you're getting a bunch of energy here. What that means is, because you're bypassing the dermal epidermal junction with most of your energy, you can safely treat in all skin types because the pigment's at the DE junction. And you were able to put far more energy deeply than you would with a traditional fractional device. So you're delivering more energy, you have the potential to get some tightening and more energy to do more aggressive treatment. So it's something that's safe in all skin types and something that's going to deliver more energy. So this is a refinement of the fractional concept that is safe in all skin types. And I think that it's a really kind of interesting technology. It's been around for like a year or two now. It's still relatively new, but that's kind of the latest in fractional lasers right now.
Man, and it's commercially available?
Yeah, it's a company called Aveva. I have no relationship with them. Yeah, so it's something that is FDA approved in the United States and commercially available.
So if you compare it to the OG Fraxel, which I used to, when I was at Mount Sinai, I used to do something called Fraxel Fridays, where I would try to, only thing I would do on Fridays would be Fraxel. At least I would try. You compare it to the OG Fraxel, maybe some of the microneedling RF technologies, which I know were really popular for a while, maybe not as much anymore. Plain old microneedling versus this new device versus my favorite resurfacing, which is fractionated CO2. Where do you see that paradigm, and where do you see this fitting into that kind of paradigm?
So look, fractional CO2 in terms of lines and scars is that's going to be that's going to be the powerhouse option that you have. There's downtime, it's painful, and you're restricted a little bit more to skin type. It was in India a few days ago, and they seem to be, and I was in Saudi Arabia last year, the people are being aggressive with these things. That's something I wouldn't do here. There's a lot more heat. The technology here, the key here is that you're putting in a lot of energy, and it's non-ablative. There isn't as much downtime. The PIH is just a completely different situation. So I think it's a refinement on the non-ablative fractional devices. Until we have more data, I'm not going to say that it's more effective than fractional ablative technologies, but there's certainly a lot less downtime. I've had the procedure myself. It's similar to the fractional lasers in terms of discomfort and redness. And microneedling, I mean, without the heat, I'm not a huge proponent of that. With the nice thing that I think microneedling radiofrequency can do is, in some of my patients who are skin type 4, 5, and 6, it's just safe. If you have an insulated tip, you're bypassing the dermal epidermal junction. So here's the epidermis, here's the dermis. You deposit the heat deep. When you put the microneedling in, it's similar in concept to what the Aveva does. I like it for that, but microneedling RF is okay for lines and scars, but I think you can do better with some of the other devices. But safe, and does it help? Yes.
That's great. Very helpful. All right, Lou, next video. Let's run through these.
So this is the 1726 nanometer laser. This is an acne laser. This one happens to be the Accure laser. What you're seeing here is it's very loud. You have this cooling that is cooling the skin very strongly, and then you place the laser on the skin, and it actually measures the temperature at the skin to figure out whether or not number one, that the skin is cool enough to do it. And by measuring the temperature of the skin, it measures the temperature when it's targeting the sebaceous glands deep. So it tells you with real-time feedback whether or not you're targeting the sebaceous gland, which is really cool stuff. So you're targeting lipids, which are rich in sebaceous glands. So you're treating the sebaceous glands, shrinking them, and the data for acne is actually very impressive. I've had really good results with this device. The data, I believe, is 80+% clearance at 1 year, and it gets even better at 2 years. Or 80% get 50% or better clearance. But I've had very good success with this. There's very little downtime. It's a little bit of a slower procedure. It takes, 30 minutes to do it. But for people with bad, cystic acne or inflammatory acne who don't want to take something like Accutane, this has been a game changer for that group because it works well. And the technology is great, and it's targeting the sebaceous gland. And turns out, just long story short, people say, is that going to dry the skin? That's not really what the sebaceous gland does. People's their skin texture and oiliness of their skin doesn't change in a bad way. Before you go through puberty, you don't have big sebaceous glands. Your skin's fine. It's the same thing when you get these lasers to treat.
I've had Aviclear for 2, maybe 3 years now. I kind of lost track, and I think if I think about the condition where the paradigm of treatment has really shifted in the past 5 years, yeah, you have your biologics for psoriasis, atopic derm, et cetera. But, I think acne now has become, for me, a procedural condition because, most of my patients, whether they're teenagers, most of my patients, I don't see a lot of kids. I see mostly young adults. They're adult women, 25 years old. They don't want to take isotretinoin. There's always a risk of pregnancy. And I think acne lasers have really shifted the paradigm to where you can treat somebody safely with a device without having to put them on a systemic medication. So for a lot of my patients in my practice, it's been like topicals. I don't really do a lot of systemic antibiotics. I try to avoid it. Topicals, maybe some procedures, maybe a 1064 laser. And then if that doesn't work, we move to Aviclear, a laser that's specifically designed for acne. And only then, if that doesn't give him enough satisfaction, do we go to isotretinoin. And I'm with you. I think most patients actually get better and do very, very well.
Yeah, and you raise a good point. There have been so many advances with the biologics and other. This is one of the major conditions in dermatology. Outside of the devices, how much has this changed since residency? I mean, it's actually
Zero.
kind of incredible. Yeah, it's actually, I never thought of it that way. That's a really good point.
Yeah, I mean, there's that new triple combination topical, which I think is excellent. But other than that, I mean, it's just using the same ingredients and putting them into a different concoction, which in my mind, if you look at lasers and you're on the forefront of this, I think the change has been very slow. Most of
Hmm.
these new devices that the laser reps will come to your office to try to push are the same technology in a different box. And it's, we need we need new stuff. We need new technology, better ways of treating patients. So I think that's one of the conditions where we really are making a leap forward. Anyway, so let's go to the
Yeah.
next one.
Okay, this is tissue microcoring. So what this is not microneedling. This is so what's happening here is the skin's being sucked in, and then it looks like a sewing machine. You can see the little needles going in. Those are basically 22 gauge needle, the same size, and they're coring the skin. They're actually physically removing the skin, and you can make it 1%, 2%, up to 8% skin removal with each area that you do. And by physically removing the skin and not using heat, you can get some contraction of the skin. So with the issue with ablative fractional resurfacing and tightening is it turns out that when you put that, when you vaporize the skin, there's a cuff of coagulation around it. In the labs here at Wellman, in the studies, what it showed was it becomes stiff. It's harder for it to close. So by using no energy here, you can do a little bit better with tightening. There's downtime. You can see there's bleeding. There's downtime. You have to do. We do injectable anesthesia, which makes it comfortable. But patients can look like a mess for up to a week, get bruising and things like that. But this is just a nice way. It helps with the accordion lines a little bit with the jowls, the nasolabial folds, malolabial folds, jawline tightening. It definitely is a downtime procedure, and it's for patients who are willing to have some downtime.
So, Matt, I'm so glad you're showing this. Do you think it's fair to say that this device has been controversial?
Well, so here's the thing. I was saying this earlier. I think there was a rush to make it controversial among people who do a lot of surgery, and I think that was, that I see that with a lot of devices, and people get threatened by things. Having said that, there's downtime. And so there's a principle here, and this was shown in the lab before it came out. If you go too aggressively, so the whole idea is that if you have a small enough hole that you're creating, needs to be like under 500 microns or under 450 microns. I think this is about 400. It leaves no scar. Like even histology, you won't even see that the core was taken out. However, if you go over it time after time, like some people were doing, and they were delegating it to people, you'll get redness, you'll get some depressions there. And that definitely happened. And I think people were, maybe less so in our specialty, were quick to delegate this, which I think is a mistake. Having said this, is this anything like a facelift? No. Is it something that helps with lines and tightening there? I feel like I got good results with it. Other people were less enchanted with it. They've updated the software. So I think it's a good procedure in the proper context for people who want to do something a little bit more aggressive. When you have laxity here, fillers and toxins aren't going to do much. So I think it has its place, but you have to respect what you're doing and respect the fact that if you're not careful with it, you can get yourself into trouble. But that's true with any device. And the other thing is, like we started our conversation about, have a frank discussion with the patient. Look, we can do this, and you might just see a minor benefit. Overall, my patients have been very happy with it because I talked to them a lot about it before I did it on them. But you need to keep all of those things into perspective, particularly with the more aggressive devices.
So what you're saying, if I'm hearing you correctly, because I heard about scarring and pigmentation and probably all the things that you've heard about as well. And because originally I was really excited about this device, and then I heard all this noise, and I said, you know what, let me just hold off and see how it performs over the next 5 years or so before jumping in. So what I'm hearing from you is that in the right hands, a properly trained physician, or maybe a mid-level, somebody you can delegate to, who knows how to use a device, you feel like it's safe and effective.
I do. Every now and then, I've had people who've had erythema, which you would have with a ablative laser. There'll be squares, and I just use a vascular laser, which is very helpful with that. If you don't have a vascular laser, that makes it harder. But if you do, they tend to do pretty well with that. The denting that I've seen, I think you have to understand there's a technique to doing it, and I think being a little bit less aggressive. I think this is true with all the fractional devices. There's kind of a happy point where like you get some efficacy, and if you go past that, you don't get much more efficacy, but you get more side effects. I think this is one of those devices, and it's just like ablative laser. Can you run into problems with this, or fractional ablative laser?
100%.
Yes. Do I think that that's like generic to doing this? No, but you have to be prepared to deal with it like you would with an ablative fractional or in a fully ablative, full field ablative laser. That's where I would put it. Similar.
Look, you can run into problems doing botulinum toxin. People think that anyone can do it, and it's just, it's not true. You can do it, but it doesn't mean that it's going to get done well. So I appreciate you saying that. I think that's the context of that is actually very, very helpful, Matt. So thank you for that.
So what I'm going to show here is this is a 6-year-old boy with Gorlin syndrome, basal cell nevus syndrome, has hundreds of basilar follicular hamartomas / basal cells that have been biopsied on him. He has hundreds of these. You can't do surgery on hundreds of things, or he's going to develop new ones. We have learned over time that pulsed dye lasers can remove basal cells. These are really small. So I figured, let's see if we can get these right when they get started. These are like 1 millimeter or 2 millimeters. And I just love this photo because it's gone. There's no scar. There's no hint of it. We've treated about 10 of these. It's been really successful so far. We put some topical anesthesia on. It's not that painful. However, in a young child, it's a little scary. But so you could do a NOR, but they're in our clinic. We treat a few of them, and if it decreases the tumor burden or the amount of basal cells, great. So that's a work in progress, but that was very encouraging to see. The other laser we use for these is a 1064 nanometer Nd:YAG. So we did, pulse dye laser doesn't go as deep as the Nd:YAG, and the Nd:YAG can use more, can get higher energy, even though it's less selective for the vessels. And we've seen about a 90% clearance rate with the Nd:YAG, as we have with the pulse dye laser. And we just do these treatments. It actually matters which device you're doing it on. You can't just translate the results from one laser to another. But what you do is you hover above the skin. So this is an example. You can see them above the skin, because if you put the cooling on the skin, you may cool enough that the superficial part won't get better. But you can see the endpoint there. You see the purpura? There is that purple. That shows that you're getting the vessels. And that's exactly what I'm doing. I'm holding it right above the skin, and I'm firing. And you're getting the purpura, showing that it's targeting the vessels. And again, about a 90% success rate. With the Nd:YAG, you need to be a little bit more careful. And the pulse dye laser is very forgiving. Nd:YAG's a little bit more treacherous. But these, let me emphasize, these are for non-Mohs criteria basal cells, not squamous cell, not morpheoform, not on the face, critical or more than 2 centimeters. Those are the ones we got a 90% clearance rate. We treated them, then we did elliptical excision, checked all the margins as part of the path, and so about a 90% clearance. Someone has multiple basal cells, it's a third-tier option for maybe going after them without doing a lot of cutting.
Matt, it's been such a pleasure to talk to you. You really are. You're a gentleman and a scholar, and really on the forefront. So, in the last minute, I want to take one more minute. Tell our listeners, what is something that you're super excited about in the future of aesthetics that maybe you're working on, maybe you have your ear to? What should we be looking forward to in the next, let's say, 5 years or so?
I just think the trend lines are towards treatments that are going to be safer, address all skin types, and with AI, I think their effectiveness and what the best settings are, we're going to learn more about. And I think it's going to make us healthier. And I think it's going to make our skin healthier. It's the largest organ in the human body. And I think that we're trending towards safer, more effective, more inclusive treatments that promote not just a better aesthetic look, but better health. And I think that's where we're headed, and that's what I'm most excited about.
Amazing. Matt, thank you so much for your time. Really appreciate you being here. And thanks to everybody who is listening and watching our first Conversations on Aesthetics podcast. We'll be back with many more. So thank you, everyone.